Right, so good evening, everyone. My name is Heidi White. I am the Group Fitness and Wellness Manager at JCC Greater Boston. We would like to thank Beth Israel Deaconess Hospital Needham and Beth Israel Deaconess Medical Center for their partnership and for helping to coordinate the Wellness Speaker Series, including tonight's topic, On the Road Back to Wellness Post-COVID with Dr. Jason Malley. Dr. Malley is a pulmonary and critical care physician at Beth Israel Deaconess Medical Center and faculty at Harvard Medical School and the Massachusetts Institute of Technology. He directs the BIDMC Critical Illness and COVID-19 Survivorship Program, a multidisciplinary clinical and research program dedicated to understanding and treating the long-term impacts of COVID-19 and other causes of critical illness. So before I turn the screen over to Dr. Malley, a few things to note about tonight's event. Most of you probably don't need a Zoom tutorial by now, but I do want to point out that you have the ability to adjust your video and your audio located at the bottom left corner of your screen. We would love for you to keep your video camera on if you are comfortable doing so, but keep your audio muted unless you are asking a question. Dr. Malley will speak for about 30 to 40 minutes, and then we'll allow time for questions. You can also ask questions in between. You are also welcome to type your questions in the chat, also located at the bottom of your screen. And finally, to make Dr. Malley the biggest square on your screen, you can adjust your view to speaker view. And I think that's it. So I'm going to spotlight Dr. Malley. Okay, and then you are good to go, I believe.
Great. Okay, thank you. Thanks everyone for joining. Since it's a small group also, I'm happy to answer questions at any point and especially hear from you about what your particular questions are about anything COVID-19 related, though I'll be talking about COVID-19 recovery broadly. And I'll show some slides, but as I'm doing slides, this is really just to provide background. And again, I'm happy just to stop and have a conversation as well. So I'm going to talk generally about COVID-19 and something referred to, you may have seen as long COVID or long haulers or post-acute sequelae of COVID, which are people who have COVID-19. And then after recovering from that first initial illness, they have persistent lasting symptoms. And there's a whole spectrum of this. So I'll talk some about the differences between people who may be sick after severe, mild or moderate acute COVID and have these lasting sequelae. And then we'll talk about our work clinically, as well as some work that we do nationally. So this is just a hypothetical patient that represents someone who we might see in the intensive care unit, a 30-year-old man, father who was sick last summer with COVID-19. And he initially stayed at home, but ultimately became very sick and had to be in the hospital, and actually spent 4 weeks in the hospital, 2 of which were on a breathing machine, on a mechanical ventilator. He ultimately survived, came off the breathing machine, and went to a rehab hospital to recover. And after that recovery, feeling like he had gotten over that initial illness, he continued to have weakness at home, had difficulty thinking clearly, multitasking, doing things that you would do intuitively without thinking about it. He was uncomfortable because of that, returning to work, and also had vivid memories of being sick and this fear of being sick again. So he was unable to work and really had difficulty with many tasks just throughout the normal day in his life. And this experience that I described after COVID-19 is being referred to as long COVID, sometimes PASC, P-A-S-C, or which stands for post-acute sequelae of SARS-CoV-2, the virus that causes COVID-19. And it generally is referring to people who have not returned to where they were previously in their health after having COVID-19. And for most people, they begin to recognize that they haven't recovered normally or as they would expect. about a month or two after having the initial infection. And this spans really from patients who had been very sick, like I described in the ICU, to people who had very mild infections. They had a few days of feeling like they had a cold or the flu. They recover, but then similar to the patient I described, they have difficulty thinking for months or a year or more. They have other symptoms that I'll describe that persist and aren't improving. So I'll first focus on sequelae after having initial mild illness, but I'll talk about these components of long COVID in general. So many people who are experiencing lasting effects of COVID have symptoms and seek a lot of testing. They're trying to figure out what's causing this. And often their initial tests don't show the cause, but they're having these severe symptoms. And the most common ones are difficulty with breathing, feeling exhausted, including we see people in their 20s or college students who had COVID-19 and have difficulty just walking around their house without having to lay down to take a nap. Fast heartbeat that for months, people, every time they stand up, their heart is racing. A feeling of burning numbness or tingling in the hands and feet. Having difficulty thinking and remembering things, as well as finding words in conversation, fluency of your speech. And then one common thing that we see also is persistent changes or loss of smell and taste. Even people who are 18 months out from their COVID infection, who everything they eat tastes like rotten fish, or things taste completely different than what they would expect. And then we also see impairments that we can more easily measure in parts of the body, like the lungs, where we see people who had severe COVID can have scarring left in their lungs. Most people recover relatively completely, but scarring can be left. People may have muscle or nerve damage from being sick in the intensive care unit, heart disease or disease of other areas. Mostly if you've been very sick in the intensive care unit, you could have those lasting effects, though it's much less common in patients who had mild COVID. And in terms of how common this is, it's really tough to pin down because so many people have been affected by COVID. You have to do a very careful survey of people to understand over time who's recovering and who's not. So one of the estimates from the United Kingdom, after a survey of over 20,000 people, found that 13% of people 3 months after having COVID had persistent symptoms of any form that weren't present prior to COVID. And they had a group of people who had not been infected with COVID called a control group. That group had about 2% of these symptoms, because some things like fatigue or shortness of breath happened for other reasons. And so it did seem much more common after COVID-19 to have persistent symptoms. This is another study from China that followed people who had been in the hospital. And they found that 1 year after having COVID-19, about half of the patients had one symptom that was still persistent and wasn't present prior to COVID. And that was twice as common as a comparison group of people who were in the hospital and didn't have COVID-19. So again, you could have fatigue or shortness of breath from many other causes, but if you had COVID-19, it was twice as likely that you would have these persistent symptoms. So I'll talk about some of these symptoms in the reference to patients who had been in the ICU in particular. And this has long been known well prior to COVID that people who became sick enough to be in the ICU and had to have things like breathing machines supporting them or other devices or machines to support them and help them survive, they frequently didn't recover to where they were before, and they would be left with this burden after leaving the hospital where their health was really clearly different than it was prior to the hospital, and they had these lasting effects. And this ultimately became termed the post-intensive care syndrome about 10 years ago, or PICS, P-I-C-S. And it described these symptoms that we were finding persisting in patients after they had been either on a breathing machine or with a severe infection in the ICU. And it includes difficulty with thinking. About a third of people a year after being in the ICU have difficulty with memory and thinking. Changes in mental health, either from these lasting symptoms or disability, or from memories of being sick, including depression, anxiety, and post-traumatic stress disorder. And then changes in their physical abilities. About a third of people a year after being in the ICU also still have difficulty with common things around the house, like walking around the house, dressing and bathing themselves, shopping, doing daily tasks. And we've done many studies with patients and families after the ICU. This is just something that encapsulates this concept from one study I did several years ago, that a patient described not being able to remember any of their ICU stay, which is very common. Most people we have on breathing machines have almost no memory of being on a breathing machine and very foggy memories of the days after that. And this patient said it's hard to get used to the idea that you needed help, that you were essentially handicapped. And this reflects really, even for young people, a dramatic change in your personal identity as you're recovering from such a severe illness, because you could go from being a healthy, athletic person, completely independent, to being fully dependent on others to help you get to the bathroom or get dressed or eat. And when we assess actual cognition, the memory and thinking and people's ability to follow different tasks, one of the things we do is ask them to reproduce pictures, standard pictures, because it requires both thinking, using your hands, having a short-term memory, and being able to draw what you see in front of you. And this is just from a study illustrating 3 different patients, a 69-year-old who had a blood clot in the lungs and had good recovery, an 89-year-old who had pneumonia and had some difficulty, and then a 72-year-old who had ARDS, which is a severe pneumonia, essentially, and was minimally able to reproduce this picture. And these were people prior to their critical illness who had no known difficulty with cognition. And this quote is from a colleague at Duke in North Carolina who did similar studies interviewing patients and families after the ICU. And one patient summarized this as feeling like I was in a cloud or something. I had no attention span. I couldn't get past 2 sentences before I was wondering what I was reading. It didn't stick. I felt like I was brain damaged. And to follow up on that, with patients surviving COVID-19 from our ICUs, we have been tracking their recovery. And this is a study of 50 patients who were on breathing machines with COVID-19 and survived, left the hospital and recovered. And we followed up with them to see how they were doing. And we used standard tests that measure different things like thinking and memory, physical abilities, and aspects of mental health, including anxiety, depression, and post-traumatic stress. And we found in these groups, 30 to over 50% of people had abnormal testing in these different areas: cognition, physical function, and mental health. And 18% of the 50 patients had abnormal testing in all of these areas, even 6 months after surviving the ICU. We also broke down the areas of mental health into depression, anxiety, and PTSD questions. And we found again that all 3 of those were quite common 6 months out. And again, 18% of patients actually had depression, anxiety, and PTSD all combined. And so to summarize that aspect after the ICU, there are each year about 5.7 million people who have to be in intensive care units. And the vast majority of people survive and leave. This, even with COVID-19, what you may have read in the news throughout the pandemic, we published studies of our patients in the Boston area, and over 80% of people who were on breathing machines survived. So most people, even with severe illness, survive. And so then the question is, how do we help people who we know will face these challenges recover. And I'll talk about what we do to help them. But we know now long-term difficulties are common. They're generally under-recognized. They affect families as well. Families have their own stress, of course, and their own post-traumatic stress, flashbacks and fears from their loved one being sick. And these issues of survivorship, meaning the challenges that people face when they survive being this sick, are rarely addressed. There aren't many programs that address survival of severe illnesses. And COVID-19 has really sparked a lot of new programs because there has been so much more recognition of these long-term effects in COVID, and so many stories that are published now in the media about COVID survival. So I'll now talk about COVID after mild initial illness, which when you hear long COVID or people talk about COVID recovery, for the most part, they're talking about people who have had mild illness and seem to have these difficulties that are way out of proportion to what you would expect. You would expect if you got a cold or if you had 3 days of some flu-like illness, you'd recover and you wouldn't feel short of breath for 9 months after that, or you wouldn't have difficulty with your memory or thinking for a year after that. And so it seems really out of proportion to how sick people were. And that's what's getting, I would say, the most attention is long COVID after initially having mild illness, which includes affecting people from children. Kids are having this in teenagers all the way to adults of any age. So while long COVID was this kind of a mystery, or presented as a mystery as it came about, and we don't really understand the underlying what's going on exactly within the body well, it's been described these persistent syndromes like difficulty with memory and thinking, shortness of breath, severe fatigue, and other symptoms after viruses for a very long time. This is a report from the 19th century. The Russian influenza pandemic happened at the end of the 19th century, and there were a lot of medical reports written in journals about the persistent symptoms that patients were experiencing following that. And there was a recent paper, actually it's now a year ago, that described this COVID long haulers or long COVID in comparison to what we've seen in the past after other illnesses like this Russian influenza, and how there are a lot of similarities. We're seeing the very similar pattern of symptoms that we have known about for over 100 years. But really in medicine, these symptoms that persisted after infections never got a lot of attention because people didn't understand why they were happening. It wasn't clear what the best treatments were. And in our lifetimes, at least, something to the magnitude of the COVID-19 pandemic hadn't occurred. So we didn't have such a large number of people who were experiencing a virus at the exact same time, and then such a large number of people reporting persistent symptoms. So long COVID has really brought to light what probably has been experienced by people for a very long time after viruses and some other infections, and we just haven't really given it as much attention in the medical community. SARS, the prior SARS virus that was around 2003, actually left many people also with these lasting symptoms. And so these are just some papers that described issues with breathing, exercise, fatigue, pains, depression, changes in sleep, insomnia, that were being seen in lots of people after the previous SARS virus, which primarily was in Asia, and there were cases in Canada as well, and very, very minimally in the US. And so after COVID-19, just for your interest, I'm showing a few studies and the basic results of them. These are patients who were studied 6 to 9 months after having COVID-19, hospitalized and non-hospitalized. And they were contacted to understand their symptoms at the time of their infection, and then 6 to 9 months later. And this is showing the percentage of patients. The height of these is percentage. And the different colors are, on the left, mild illness and severe illness acutely, so at the time of infection. And the orange and yellow are mild illness and severe illness at 6 to 9 months. So you can see fatigue is relatively common in people who have COVID-19, but at 6 to 9 months, it remained quite common. 15 to 25% of people, depending on how sick they were initially, still were experiencing fatigue that far out. Loss of smell or taste, which is one of the more kind of striking or unusual aspects of COVID that people recognized relatively early on was happening when they were getting infected. Again, happens in about 40 to 50% of people with COVID. Actually, was more common in people with mild initial COVID. And about 10 to 15% of people still hadn't recovered their sense of smell or taste fully when they followed up with this group. And then trouble breathing is by far the most common symptom of people who have severe COVID. Almost all patients have difficulty breathing. And by 6 to 9 months, about 10% of people still had difficulty breathing. And it was equally common or even slightly more common in people who initially had mild illness. And so this group that had mild illness were not very sick by the standards of needing oxygen or having to be in the hospital. And yet 6 to 9 months later, they're still having these persistent symptoms relatively commonly. This is what's really caught the most attention and what is generally referred to as long COVID. Just one other kind of unusual and interesting aspect of the symptoms was the loss of smell that people recognize. Patients, when you get long COVID, when you have COVID-19, very commonly lose their smell, or they have minimal smell and therefore minimal taste. And this was a survey with tests of smell, specific tests for almost 100 patients who were followed for a year after having COVID-19. And interestingly, a quarter of the patients, 25%, reported something called, well, they were reporting these symptoms, which are described as phantom smells or parosmia. Phantom smells are smells that occur out of nowhere that aren't explained by anything. And they're almost always the smell of smoke, cigarettes, or natural gas. And parosmia is when things smell incorrect. There's something like a chicken in front of you and it smells like rotten fish. They're very commonly unpleasant smells and unpleasant tastes, unfortunately. So people who have persistent parosmia have a difficulty eating because no matter what it is, things taste rotten or metallic or otherwise spoiled. And it makes almost all foods really unpleasant. Fortunately, most patients who have loss of smell fully recover it, but still at 1 year, 4% of the patients hadn't recovered their smell fully, which is pretty extraordinary. And one of those patients had this parosmia, this incorrect smell at 1 year. And I've seen a fair number of people, including people who have searched anywhere they can, looking online, traveling the country, contacting doctors around the country to try to figure out how to solve their parosmia in particular, because they can't enjoy any foods anymore. And it's really challenging. That those phantom smells and parosmia have mostly been described after head injuries, traumatic head injuries, where people have physical damage to the nerve pathway of smell. And we think COVID-19 has caused the damage to this pathway, but healing nerves takes a very long time, and it's hard to know what the recovery will be. We do this smell training with patients, along with some other therapies we're trying, which is smelling specific essential oils twice a day for at least 3 months. And we sometimes do some other medications along with that to try to help heal the nerves. But this is like a patient using their muscles to recover their strength after having a stroke, where the nerve has been damaged and you have to stimulate those pathways. smell training is stimulating these injured smell pathways by using different specific smells and trying to get patients to have recovery of those pathways faster. And it had been proven prior to COVID to be effective after head injury. So we're hopeful that it's helping some patients recover. Unfortunately, we do see people who we try everything and they still are having changes in smell this far out. And in that case, we really try to focus on nutrition, getting them what they need as we hope that they heal, knowing that there isn't a clear solution to the injury to that nerve pathway, but at least we can try to make their quality of life the best it can be. So what we've done to try to address this is initially, prior to focusing just on COVID-19 and long haul or long COVID, we were focused on patients who had been in the ICU for any cause, but mostly had been on breathing machines. And we had a team assembled that really was focused on all of those needs that I talked about: mental health, thinking and memory, lung function, lung abilities, physical function, and supporting them through social workers, making sure their medications were correct through our pharmacists. And so this team was built up mainly for patients surviving the ICU, but we've shifted also to add patients who have had COVID-19 of any severity. And I would say at this point, about 90% of the people we see had initial mild COVID-19 and had recovered from that, but have these lasting symptoms like I just mentioned. And so we started with a small group that included neurologists, psychiatrists, physical therapists, social workers, a geriatrician. And we've grown to this group as kind of our core team that includes a number of physical and occupational therapists, breathing therapists, cognition experts, psychiatrists, several sleep and pulmonary disease doctors, and a handful of social workers, as well as researchers. And we have a nurse who coordinates this with us. And these are all the specialists who kind of encompass all of those common symptoms that I mentioned. Difficulty with thinking and memory. We work with the neurologists and in particular occupational therapists who do brain rehabilitation. For physical impairment, people who are fatigued and feel weak, we evaluate their lungs and heart frequently to make sure that that's not the cause. And then we have them work with our physical therapists on very gradual programs that slowly reintroduce activity so that we don't overwhelm their bodies and cause setbacks. And it can take months to recover, even after mild COVID, if you have severe fatigue. We also work with patients who have very commonly sleep difficulties. That's very common after COVID-19. And we work on research that I'll mention. And we've seen over 500 patients, and we have this large team that's over 13 people now. Our social workers run routine support groups for patients with long COVID, as well as patients who have survived the ICU and their families. And we have ongoing studies, including a trial of a specific breathing therapy techniques to improve lung capacity and improve shortness of breath in people who have persistent shortness of breath. And something called the Brain Fit program, which is a form of brain rehab that had been used for people after brain injuries, after trauma. And we're using it after COVID-19 for these patients who have persistent cognitive impairment, difficulty with memory and thinking. And we've worked with a national collaborative that I co-chair of over 40 clinics throughout the US that study and treat patients after COVID-19. And we've developed a process of reviewing the medical literature, voting on our thoughts on the best approach to assessment of patients and treatment of patients, and then bringing that all together to publish our recommendations so that other people seeing patients with persistent effects of COVID can learn from the experience of these centers and give patients the best treatment. And we've focused and have written up documents on the recommendations around fatigue, breathing discomfort, cognitive impairment, And now with colleagues at Boston Children's and other children's hospitals around the country are doing recommendations around pediatrics, because there's really nothing to guide pediatric care of patients who are having persistent symptoms. And it's actually common enough that many people, parents and others, email me, people I don't know, just to ask advice about where they should go for their children who are still having these persistent symptoms, because there are no easy routes. And though Boston Children's now has a program, most people aren't aware of it at this point. And we've published the methods for doing this, which is really this iterative voting process. And the approach to helping patients has been published and presented in the CDC webinars, as well as at national meetings. And we are also launching a study called Recover. If you go to recovercovid.org, the National Institutes of Health is sponsoring a nationwide study that's going to try to describe long COVID, the recovery, and understand the cause of why people are having these symptoms, which hopefully will explain for over 100 years why people have been experiencing symptoms after viruses. So we'll be enrolling people in this study in the coming months and reaching out throughout the community to get people who are infected with COVID or have long COVID to participate, so that we can help people understand what's going on in their bodies, what the cause is, and ultimately get to what the best treatment is for these symptoms after viruses. And that just briefly, in terms of vaccination, which commonly comes up, patients after infection are safe to receive vaccine really at any time. Some people wait 30 to 90 days, but at any point after recovering, it's safe to receive it. And it's been very well proven to boost immunity in addition to having the infection. Among people who have long COVID, there are some early studies that patients may improve after having after having vaccination in terms of their long COVID symptoms. The majority of people who participate in those studies don't have a clear change, but we get many questions also about if it's safe to have the vaccination if you have long COVID. And it seems to have been clearly proven safe and even potentially beneficial for the long COVID symptoms. We think the risk of new COVID infection in those patients is much more concerning than the risk of any side effect from vaccine. And boosters are similarly safe, even in these patients who have had COVID infections. So to summarize, and I'm happy to take questions, we really focused on this team approach to address the complex needs of these patients who really have symptoms from head to toe. And it's hard to have any one medical specialist suit their needs. So we've tried to build a team around those needs. And that's where we're helping these patients recover from COVID-19. Social work has been really essential to help supplement that and to support patients and their families. And in the ICU, really the best approach to helping recovery is to work closely between the medical team and families, have excellent communication, to teach and educate about what the expected recovery challenges are, and then to connect with clinics like ours who provide post-ICU follow-up to ensure that people are on the right path of recovery, that their lungs are healing, that their other treatments are in place, and that they're getting the best care to help them return to where they were prior to being sick. And after mild COVID, really many people go on for a long time having these symptoms and not knowing where to turn, or trying to search for answers without getting them. And there's a lot of help out there now from clinics like ours, and there are many throughout the country now that you can find online. Specialists, even without affiliations with long COVID clinics, are seeing lots of patients with these symptoms, and so gaining more expertise as well. And certainly resources like our physical therapists, occupational therapists who help with body and brain recovery have been the most helpful thing we've seen for patients so far, because unfortunately, there isn't a clear treatment for the underlying cause of long COVID yet. We've tried many things, and I've seen many people who have come to us having previously tried treatments or supplements or anything that they have read about online because people are really searching for any answer. And there hasn't been any pattern to something that clearly is helping this from a medication perspective. So we really focus on helping the individual symptoms, putting together the right rehabilitation plan, and doing this research to try to discover the cause and to discover what the best treatments are. So I just wanted to acknowledge the team again, and I'm happy to take any questions. And this is also my research team. Bruce Landon is a health policy professor at Harvard, and Jen Stevens is a professor at the med school. Thank you.
Thank you, Dr. Malley. Anyone have any questions? Great information. One question in the chat.
Yeah.
Have you seen any prevalence of autonomic issues in patients? Is there anything being done about this? Oh, let's see.
Yes. So yeah, these are great questions. So autonomic issues are a big topic, and that's one of the other topics we're addressing with that national collaborative that's ongoing right now. They're working on publications around that. So a lot, or perhaps all of long COVID head to toe seems to have a common thread of nervous system impact, from the cognitive aspects and headache to very fast heart rate, which we believe is from an autonomic dysautonomia or an autonomic impairment. Digestive issues, which can be autonomic as well. Neuropathies, people with pain in their hands and feet. And even the breathing discomfort when people are having severe shortness of breath with different activities, but it's not explained by a change in their lung function or their heart health. It's possible that it relates to the sensors of the lungs or the nervous system. And that's also seen in autonomic issues. So we have worked with people who prior to COVID, their whole focus has been on autonomic diseases as part of this national collaborative. So they've begun to see patients with COVID with these patterns of autonomic issues like they were seeing prior to COVID-19. The real challenge is what to do to help people, because after long COVID, the most common autonomic issue people are having is very fast, inappropriately fast heartbeat, fast heart rate when they stand up and move around. Sometimes that's been part of something called POTS, P-O-T-S, where people stand up and inappropriately their heart goes very fast, and they may have other symptoms as well. And the treatments have been things that either improve blood pressure, slow the heart rate down, and then reacquaint the body with standing by a very prolonged exercise therapy that starts in a lying down position for weeks to months, and then exercises in the seated position and then standing. So we try to combine all of those. Some patients do end up taking these medications to treat what would be treating POTS. They engage in exercise therapies. Some of the other symptoms that affect the digestion and other autonomic symptoms can be tough to treat, because it's really, the treatments even well prior to COVID have mainly been focused on trying to help the symptoms, because the underlying causes of things like POTS haven't been well understood. So, but that's a very common thing we see, definitely. And then, so the healthcare and taken seriously is incredibly common too. And we very often see people who come into our clinic and have been to emergency departments, urgent cares, and others for things like shortness of breath that doctors can't explain, or fatigue. And people have very commonly had the experience that they haven't been taken seriously. That was especially true earlier on. I think the articles, including in national media, about sequelae of COVID and long COVID have raised awareness, hopefully throughout most of the medical community, but we still see this as a problem. And for most of the people that we see with things like breathing discomfort, there isn't a persistent scarring to their lungs. There's another explanation for why they feel short of breath. And so that's what we work on. But that's the problem is people like seeing some sign on an X-ray or some test. And if they don't, they move on or believe that it must not be there. And of course, that's not the case. There's a clear injury that's affecting patients after this virus. But that continues to be an issue. Access to clinics is tough. We have worked with a lot of people around the state and through this collaborative around the country to create more clinics. So there have been many more groups focused on this within Massachusetts and New England. Initially, we were seeing people from all of New England, and now in New Hampshire and Maine, there are groups seeing patients, but that still remains a really big challenge. And trying to get, I think that's the problem outside of COVID in every clinic right now in medicine, but we're trying to get patients in as soon as possible. Now triaging through our nurse who can help get patients to the right team members quickly. The NIH study similarly has been, for us, at least waiting to see when this gets started and when it picks up. It was announced a relatively long time ago at the beginning of the year, and we're still waiting and hopeful that the study will launch and we'll begin enrolling patients in the next month or so. But that's unfortunately another challenge that's been a bit out of our hands, but I'm hopeful that there'll be more treatment studies because and our patients would like to try different treatments. People are willing to try things that are reasonable and safe, and those have been slow to pick up too.
Anybody else? Any other questions?
I'm happy to talk about any questions people have.
All right.
Hi, I've got a couple things on my mind.
Oh,
Sure.
terrific.
Okay, thank you. I'm a clinical pharmacist, and I've been following long COVID ever since long COVID occurred, ever since we were about 6 months out from the original infection. And at the time, it was considered that 6 months was about the time that you would start seeing these things. As soon as that became apparent, it also seemed that that time frame began to gradually and steadily shrink down to 5 months, 4 months, maybe 3 months. And now we hear you tonight saying that it's really, 4 to 8 weeks, a month or two. I understand that probably occurs because there's much more information than there originally was. But you have a take on that, the idea that this was recognized maybe 6 months out, and now it's something that seems to happen a month or two afterward.
Yeah, that's a good question. I think that has actually been, the World Health Organization had a survey of all the long COVID clinics and patient groups to try to create a definition. Mm-hmm. And one of the biggest challenges was an agreement on what the time frame was. And I say when I describe the time frame, the word generally speaking, this is the time frame, because it does vary significantly. We have patients that fall into different buckets. Mm-hmm. Some people, especially with things like shortness of breath and chest pain, had those as symptoms of the initial infection. And it may have been a short infection, but 4 to 8 weeks later, they're still having equally severe symptoms. And so that strikes us as abnormal. And those people, in our recommendations, you should start to really evaluate them and shouldn't say, let's see how you are in a few months. Whereas there are others who, they feel like they actually recover fully. And then they come to us 4 months later, and for no explained reason, their hands and feet feel like they're burning. They have
Right.
these sensory neuropathy symptoms
Yeah.
and neurologic things that are later developing.
Mhm.
So it really varies a lot by which symptom, and this group of continuation of the initial symptoms versus recovery and then development over the course of months. And I would say from the patient's perspectives, also someone who's young, working, and has severe cognitive impairment that they're just shocked they can't open an email and even read without getting to the end and comprehending it.
Yeah.
That is incredibly concerning, even in a few weeks from the infection for most people. Whereas there are others who they're having this kind of funny feeling in their chest, or they've noticed their heart rate is faster than it used to be. And they often are just waiting to see, is it improving? And they kind of give it a few months and see, has it improved? And if it had, although that's a common symptom for many people that improves by 6 months, for others it doesn't. And so in the 3 to 6 month range, they end up trying to seek an explanation. So I really put it up to the patient's perspective of what is most concerning. And I would, if I were in their position, want earlier evaluation. And so that's why in our national group, we kind of tended towards recommending that at least a basic medical visit, even if it's just with their primary care doctor at that point, should happen at this earlier stage of 4 to 8 weeks. But the WHO ended up, we kind of as a group agreed on 3 months as the time where if symptoms persist, you should be confident that that represents a lasting sequelae of COVID, and not just someone who's slow to recover.
Now, in the earlier days of the long hauler experience, long COVID experience, there was easily an array of at least 15, 16 different symptoms that patients had. Now they're talking about, there might be an array of over 100 different symptoms. And my impression is that, and I have no basis for it except what I'm hearing and reading, is that these are largely neurologic in origin.
Yeah.
And you kind of touched on that.
Yes. Yeah. So I didn't show one study because it's so impossible to put on a slide 100 symptoms, but there's one of the early surveys that engaged a group of people on one of the big I think it was one of the big Facebook long COVID groups that grew to hundreds of thousands of people around the world.
Yeah.
They surveyed people for what the symptoms were that were new since having COVID-19. And the figures listing these go on forever because they put them in different domains. And if you're interested, I can even share through Heidi that paper. But they go completely from head to toe. And I agree that most, if not all, have a common thread of being in the nervous system or immunologic. And it's one of the mysteries has been most people who are having these symptoms will undergo available testing of the immune system, looking at blood tests for inflammation and other things. And for the most part, it looks normal. And it's a question of whether there are other subtle changes that are not normal, but not at the threshold of what our basic tests are, or if there's been just an injury in the nervous system. And that's what explains for most people such a long healing process, because the nervous system has a very slow repairing process.
Well, that seems to be a question, and I would love for you to correct me if I'm wrong, but it seems as if evidently it's a respiratory condition, but the thinking is in some quarters that this is a neurological problem or a vascular problem.
Yeah, I think neurological definitely fits very well. There had been a lot of talk about small blood clots or if it was vascular. There have been a few small studies showing that there are abnormalities in the blood vessels in some people with long COVID. And some people get something called COVID hands or toes, where their hands or toes intermittently turn purple. So that suggests there's poor blood flow to that area, at least periodically. In this, getting at exactly what's been injured in the nervous system, for people who unfortunately didn't survive COVID and have had autopsies, there haven't been signs in the large studies, the well-done ones that I've seen, of the virus itself persisting in the nervous system, but there have been signs of clear brain injury. And in some patients that we test with detailed MRI studies, not kind of routine ones, but ones used for research, we see very subtle changes similar to what we see in people who have traumatic brain injury.
Mhm.
So we think that perhaps the body's response to the infection could manifest in some sort of nervous system injury, but we really don't know beyond that, at this point at least, what that underlying cause is. Is it the immune system, something driving this constantly, or is it a result of just an injury that happened with that first infection that then lasts?
Thank you. Thank you so much.
Mhm.
All right, well, thank you, Dr. Malley, for this very informative presentation and discussion. I also want to, special thanks to Beth Israel Hospital Needham and Beth Israel Deaconess Medical Center for really sharing this important information about COVID-19. If you would like to hear this presentation again, or if you know someone who might benefit, we will be posting the recording on the JCC Greater Boston website on the Wellness Speaker Series page, which I actually did put in the chat. And you can also access the recording via JCC Greater Boston's online video platform, which is called JCCGB+. Our next speaker event will be held on Wednesday, January 26th at 7 p.m. on Men's Health and Aging with Dr. Jeremy Wyman. And again, I put the information in the chat with our website, so if you would like to register, you can do that. And again, thank you so much, Dr. Oh, yeah, I see you put the article in here.
Yes,
Okay.
for Arthur or anyone else, that's the link to that article.
Okay, terrific.
Thanks for your questions and thanks for having me.
Thank you so much.
Thank you very
Give
much.
people a chance to get that article if they would like. All right, well, good night, everybody.
All right,
Thanks again.
thanks.
Thanks so
Bye.
much.
Good night.
All right, bye.